Welcome, everyone. I'm David Covington. I'm your host for today's Crisis Jam. I'm the CEO and president at RI International, principal at Behavioral Health Link, and together we're the 5 Lanes Crisis Partners family of companies. But we're thrilled today to have a special edition around child and adolescent access to care, especially crisis care. And this is probably one of the topics that's been most sought after from our Crisis Jam learning community, more information about that. And Jeff, your young company is already making an impact on this. And I was just talking with Jeff in the run of show beforehand that it reminds me a little bit, Jim Collins used to write about the difference in companies that are more like a fox and those that are more like a hedgehog. The fox is always coming up with something, but the hedgehog just has a basic strategy that just works over and over and over again. And it's got a very clear purpose and mission. And I think this group is going to love, Jeff, hearing about the work that your team is already doing, the impact you're already making, and the vision that you have in the child and adolescent space. We've had a lot of crisis now innovators in the adult space as it pertains to facilities, but more to come from Jeff in a moment. We continue to grow our list of national organizations. We've finally breached 70. If you don't see yourself listed and you'd like to have us add, we're looking for, again, multi-state national groups. And we continue to track the special edition Go Live event with Assistant Secretary Delphin Rittman is still our #1 in terms of impact, both in the live participation as well as those who joined us on Zoom. But we'll look to break that coming up, and we'll tell more about that in just a moment. Jeff, you were mentioning, boy, it'd be great to have a calendar invite. And if you're on our newsletter, you get this. So every week in the newsletter, it shows you this information where Captain Picard he's lost it too. And all you have to do is click on these various, whether you have a Google Calendar or an Outlook calendar. You can get on the newsletter if you're not at talk.crisisnow.com. You see in the lower right there, you sign up for the newsletter. This learning community is just about to breach 3,000. We're just about 20 or 30 short of having 3,000 who are in the newsletter. And again, that's how you get to not only the calendar invite, the t-shirts that you see in the lower left, the link to today's meeting in the upper left, as well as videos, and the most recent highlights are on that homepage. Now, it's hard to believe. Richard Mckeon, can you imagine this, Richard, that we are approaching our 100th episode of the Crisis Jam?
It is amazing.
And Richard, how many were in those very first meetings in September of 2020?
Only a handful. I'd say between 6 and 12 at our very first meetings.
Yeah. So we are looking for our 100th edition. We've had a few very special editions. We had the crossover event with SAMHSA's annual meeting last September. We had the Go Live event in July, which focused a little bit more on the federal engagement. We certainly hope to focus on the states in this 100th episode, as well as what we're calling the challenge, and more on that as we get closer. But if you have ideas for special segments or content or speakers for this 100th edition, please let us know. A few things in the news. The National Journal interviewed a number of us. Hannah, who's with us today, Hannah's in our Crisis Trivia Hot Seat, was quoted. Angela Kimball. If you're reading an article about 988, the likelihood of Hannah and or Angela being quoted is very, very high. It might be Margie or myself or Richard or John or a host of other people. And then it's going to be Hannah and Angela for sure. But I thought this was really, and it mapped very well, Hannah, to the reimagined crisis that, again, the concept of the Crisis Jam right now, based upon your work, is that we're at mile 1. We're at mile 1 with a journey to come. Hannah, any comments on this article?
And this is really thank you. First of all, it's really encouraging to see coverage that is focused on the long-term effort, that, it's not about 988 capacity, our calls getting answered, which they are, it's great. But it's really talking about this is one step in the process. So it's encouraging to see reporters thinking about it in this way. And I think it's due to everyone on this call and the messages that have been reiterated at every level that we are on a long-term path to build up crisis services across the country, and a lot of work to do, and just trying to keep that noise and volume up. And sorry, you keep seeing quotes from me. I'm sick of seeing quotes from me too.
No, it's great stuff. And Hannah, you know, what happens when you get a lot of quotes is you get put in the crisis trivia hot seat. So it's coming. And then Monica Oss. So everyone has engaged 988. Monica's newsletter this week extensively quotes Wendy Martinez Farmer with Beacon Health, one of the pioneers with the Georgia Crisis and Access Line and Crisis Services. So we'll put those links into the chat text. And today's quote borrows from this week's Crisis Talk interview. Stephanie talked to Dr. Jeff Bostic with MedStar's Georgetown Center for Wellbeing in School Environments. And of course, one of the reasons we don't have more crisis care for kids is this concept that kids are pretty resilient, and it's true. But the notion is that they're like flowers. They're growing and going to be okay. But Dr. Bostic says by providing children and adolescents the support they need, we help them flourish rather than flounder. So Jeff, tell us about Mind 24/7 and how do we help kids flourish rather than flounder at the point they're in significant pain and need help.
All right, thanks, David. Really appreciate being able to speak to everybody and be in front of such an amazing group. Look forward to connecting with many of you going forward. David mentioned that he'd like us to talk a little bit about what we've been able to do at Mind 24/7, and truthfully, it's been a pretty fast roller coaster ride for us. You know, last May, May of 21, I think we were 8 people in a PowerPoint where we had gotten some initial funding to get started. Since that time, we are, we're close to almost 600 team members. We've opened 3 clinics. All of them have capability and capacity to handle kids' crisis care, as well as kind of a 24/7 urgent walk-in care setup. And we've helped close to 5,000 kids since we opened our doors last September. So it's been a pretty wild ride for us. But, you know, one of the things, even getting a start for us when we had initially approached Mercy Care here, the Regional Behavioral Health Authority here in Arizona, when we had conversations with, say, some of the bigger providers like Phoenix Children's Hospital, there was just a real need to address kids who were in crisis, who were basically just flooding emergency rooms, or they weren't finding a place to go. And so, you know, we really kind of set out to figure out what we could do. And I'll go ahead, Dave, you can hit the next 2 slides. I mean, everybody's seen this every day in the news. There's another article, there's another story, there's another study talking about just the sheer demand of services that kids are putting into our system, and our inability to necessarily meet that huge wave coming at us. I would say that this was a challenge before the pandemic. We weren't quite getting to what we needed to get to. You throw in the pandemic and everything since, this has now become really what I call the second wave of the pandemic. We are seeing these youth really hit the system hard. I think everybody is trying to figure out what to do, and we're fighting kind of with our hands tied behind our back. Dave, you want to kind of? And there's lots of studies. I think this group's going to know them all incredibly well. What I would tell you is really interesting for me is just really kind of the last piece of this is about half the kids who really need the help in this country are just not getting the treatment they need. They don't have a way to access the system. The families, the parents, even what I would say the foster system, the departments of child services around the country, they're all struggling with what do we do? Where do we go? So we can kind of go from there. And so when we built Mind 24/7 and the way we thought about it, was let's go create a new front door. And let's take some of the stuff that we've learned along the way that we think was really useful, but then let's really establish just a new way to package how we do everything. And you can go to the next one. And so we kind of started with this philosophy. We want to build a new front door to the system. We got to have a few things that we're going to do. One is we're just going to always say yes. And I've heard the phrase no wrong door. Candidly, I have a little bit of a challenge with it because there's a negative component to it. There's no wrong in this, and we shouldn't be talking about no. We should be just saying, what do we got to do? What's it going to take to make this work? And so when we said we're going to accept everyone, we didn't worry about the acuity. We didn't worry about what were some of the physical health complications. We were not worried about how they were going to pay. What's their insurance status? Who's covering? And probably the biggest thing that we said, which was really interesting because just it'd been built up over time. I think we'd done such a phenomenal job creating access to crisis services for adults here in Greater Phoenix. We just hadn't done the same thing for kids. And so we take everybody, but if you're not 18, we're not gonna, we can't help you. And I used to say it felt a lot like, you're not 40 inches tall, you can't get on this ride. And so we said, we're gonna take everybody. And since that time, I'll tell you, we've had them as young as 3, and we've had them as old as 96. So, the need for the youth has been well established, and it's led to kind of our unprecedented growth in the market. The second thing we said was that we were going to do was that we're going to say our clinical outcomes have to drive what we do, not our business arrangements, not our contracts, not our fee schedules. We had to decide that what we were going to do was going to be built upon doing the right thing for, for the patient. So it meant not necessarily doing as many assessments or tests or whatnot, just because we could and we could make a little bit more money. It didn't mean holding on to a patient longer. It didn't mean letting them go quicker, unless that's what really the patient needed. And so when we freed up our clinical team to not worry about that, and we really put the onus on our billing and contracting teams to figure out how to get paid for the value that we create, it freed up our clinical team to do, I think, amazing things. And I can talk to you a little bit about that as we go along. So that all sounds great. I mean, I'll talk a little bit about that last point, David. I also think when you become that front door and when you say yes to everybody and when you do the right thing clinically, you are going to get everybody. And that has proven to be the case for us. We opened our first clinic and I kind of conservatively assumed it was going to take us 6 months to get ramped up. It took us 6 weeks. And so, and that's been the case with both of the other buildings. They get full quick. We get to capacity and the needs there in the community. But we also realize that as we serve as that front door, one of the things that we as crisis providers can become is the hub of that community. And we think of this ecosystem of places that will send us patients and places we send patients to. And we serve as this kind of connecting point to all of them. We can provide them technology, we can provide them data, we can provide them resources, and we'll establish that. That's one of our commitments, is we have to kind of lift the entire community in the neighborhood up just because of the role we play. All right. So that all sounds really good, but then you got to answer the question, what do you actually do, right? So we kind of have 3 service lines, and this is what we thought made best for us. One is we run a crisis stabilization unit, 24-hour observation level of care. And I think it's really important to talk about what the purpose of each of our service lines is, instead of just necessarily talking about who we treat or why we treat them. What is the value proposition for each one? And we made it really clear for us that us running our crisis stabilization centers was going to be really focused on preventing an unnecessary inpatient mental health admission. And so, like most everybody else, you get a lot of patients who would otherwise go to level 1 admission. Our real focus was, how do we get them dispositioned back to the community in a safe way to the best possible place so they maximize their chances of long-term success. when you do that, it makes it kind of really crystal clear about what the goal of it all is, right? And unlike a lot of the other groups that do this around town, one of the things we just made this decision that, and everybody does it for different reasons. We just made a decision that we're not going to run our own inpatient bed or subacute bed unit. It just seemed too big of a conflict of interest for our clinical teams to focus on preventing somebody from going into an inpatient bed, but then trying to make sure our own were filled. And the economics of running those units are really tough, right? And there's a lot of compliance and regulatory requirements. And we just think that's better suited for some partners of ours around the community that do that well. And for that small percentage of patients that need that service, we're going to make that referral look like. And so for us, you'll see, I'll talk about it a little bit before, on average, about 70% of the patients that come through our crisis setup end up being able to be discharged home. And that makes it a really clear value proposition for us when we go talk to the payers, right? We also know not everybody comes in through an emergent, 70% is what I said in the back. So we know that not everybody comes in emergent fashion, right? It's not that high acuity, but it's urgent in their needs. It can typically be they need a medication refill. They feel like they're having real challenges and they just need to talk to somebody. So what we ended up doing was kind of extending this idea of a walk-in urgent care solution, and then tried to really say, what's every way we can boost this thing? So we run this walk-in urgent care setup 24/7. And our target, and we've been able to meet it, is that you will see either a psychiatrist, a nurse practitioner, or a PA in under 20 minutes with no appointment. And we've been able to meet that. And our whole goal in that setup is to just prevent you from going to the emergency room, right? Sorry, I know there was a question around how the pandemic. So, the truth is, I think what we've seen is that a lot of the kids, a lot of the parents are coming and they don't know what to do. I mean, most families can't tell you the difference between a psychiatrist and a psychologist. They don't know how to navigate the system. They don't know what kind of resources they need to engage in. And what ends up happening for us is Psych Express becomes this really simple, easy button, right? And honestly, when our patients come to the door, the only person they want to see really is the provider. And when they can see them right away and they understand what the game plan is, it reduces all of the anxiety, all the stress, and we get a much more, let's say, convenient and collaborative patient and family to work with, because the plan has been laid out right away, right? And right now in our Psych Express, we're really proud. Door-to-door time for us is 1 hour and 20 minutes. And sometimes it gets to 1.5 hours. But that is so much better than an experience for a person going to the emergency room, where you're probably lucky to just get your vitals taken in 1.5 hours, right? And then one of the things we realize is whether you come in emergent or urgent, we know that a lot of our patients need a little bit more help, right? That they need to be connected to the rest of the ecosystem in a better way. And honestly, David and I have had this conversation. This is where I think our crisis model goes from 1.0 to 2.0, but it is building this bridge to the rest of our ecosystems that we are in. And for us, we do this with what we call Psych Progressions. Think of it as an up to 90-day set of activities where we take the provider, a licensed therapist, and a case manager, a social worker, and we have that team work very tightly around each patient to come up with a customized plan for them. And I can tell you, this has done an amazing thing for a lot of our patients. We do have peer and parent supporters. We have all that. I can tell you there's a big team, and I'll get into that here in a second. But in Progressions, one of the things that we do is when you wrap that all three of those resources in a coordinated fashion, I think there are a lot of places where patients may have those relationships, but they're not working in such a tight collaborative way. The handoffs aren't necessarily done right. And one's really driving the bus then as opposed to the other two. Doing all three of these things, we've been able to take where we used to see the same people coming in to either crisis or express 40% of the time, 30, 60 days later, we've taken that down to about 10. And we did it in one of our buildings. It's been amazingly successful. We're starting to launch it in the other two. And you can even see the other two, without having a robust progressions effort, had a tougher time getting the readmission rate down. So we're very excited about how that works. Real quick on the ecosystem. So this is how we think about it. We think about all of these as our partners in the community, and we need to solve each of their problems, their major pain points. And so obviously the hospitals and the emergency rooms are a huge partner for us. We get a good deal of patients referred from there. But their problem is patients are overflowing their ERs. They can't handle these patients. They don't have the staff to do it. They don't have the facility structures to do it. Phoenix Children's, when we first started, and Mercy Care was amazing, kind of helping support us as we go through this. Phoenix Children's would routinely have 20, 30 kids in their emergency room with psych needs, and they had nowhere to go. So we work closely with them, and that's down to 2, right? I can talk about the rest of the ecosystem. I do want to talk a little bit about our buildings. We are high profile, big, these are 15, 20,000 square foot facilities, seeing 100 patients a day. All of our staff is in the building. All of the disciplines are in the building throughout the day. And we're taking care of, roughly 50 people in crisis. Most of our buildings are half kids, half adults in that setup. But, we can flex and we can take on more kids or we can take on more adults. Dave, you want to go next one? Just to finish with some stats. Like I said, 70% of our crisis patients, we avoid a level 1 admission. We're able to get them discharged home. We think we've done a study just in Phoenix alone with our 3 buildings as they've been growing. We think we've saved on a run rate basis about $56 million for the market. That certainly has impacted and helped us as we've thought about negotiating with payers. I'll tell you a little bit. The buildings are set up so that there's a separate kid entrance, a separate adult entrance, lobby. The kids never see the adults never see the kids, but we do leverage the same staff to handle both sides of the building. It's been 20 minutes to see the doctor, and it's an hour and a half in the latest month, door-to-door time on the express. And we're not getting the easy kids. We're getting the challenge. We're getting the no-fly list kids that Department of Child Services has a tough time placing anywhere. We're getting a fair number of autistic kids. We're getting a lot of sex trafficking kids. We do, and to answer the primary care, we do bring in pediatricians and family practitioners to come in each day to round on any patients that are in crisis. And then we're working hard to connect them to the right primary care when they leave us.
Jeff, wow. So I was going to sort of lead with, you have a history with ACOs and health plans, and how did that influence some of the work that you're doing? But I think that started to really show up in that last slide where you were putting these metrics to the cost avoidance and impact. So you're talking about the benefit to the individuals and their families, to your partners, to the health plan. And now we see how in a very short period of time, you become Mercy Care's Provider of the Year here in Phoenix. So let's go to a roundtable for a moment. I may have a follow-up question depending on time. But Sharon Hoover has been one of our leading child and adolescent gurus in this crisis jam. Sharon, your reflections on Jeff's version of 2.0 and a Crisis Now provider really leaning hard into kids and teens.
Thank you so much, David and Jeff. That was fantastic to hear about. Again, I'm Sharon Hoover. I'm based in Maryland. I'm a professor at the University of Maryland School of Medicine, and I co-direct the National Center for School Mental Health. I'll throw a couple of links in the chat. And I've been really pleased to be a part of this conversation for a while now. I shared one link, I think it was a couple of years ago now. It's hard to believe it's been that long, that I worked with NASHBID and partners to address kind of thinking of shifting from 911 to 988 and what would that look like specifically around children and adolescents. So just shared both our centers link and that documents link. But just a couple of reflections, Jeff, on what you shared. First of all, I just love the idea of kind of adjusting from the no wrong door language to we always accept everyone. I think it goes right along with, you know, the aesthetic and the intent of your work in terms of making it a welcoming environment and service. When I saw the Mind 24/7 building, I wanted to go because it looks like somewhere you want to go. And I think that that's critical. You know, in the document I shared, we talked a lot about not just kind of having, you know, separate child and adult spaces, which I think is critical, and folks can learn from how you've done that well while still leveraging the staff to serve both. But also just creating, you know, developmentally attuned and aesthetically pleasing places that feel less stigmatizing. So I think, you know, whether you had interior designers you worked with or, you know, architects, it would be really helpful to get down to that. You know, I learned a while ago about trauma-informed architecture. And in our school mental health business, it's not something we often think about, the architecture of a building and how that can be mental health promoting, but it looks like you've done a really good job there. One of the things I thought about when you talked about that shift in language toward kind of a more welcoming and positive approach, I wonder about when thinking about the outcomes you mentioned. First of all, I think it's, you know, right spot on that you've, you know, said that part of your success has been for each service delivery mechanism or each service line, you identified a very clear target outcome, which helps you in terms of identifying what does success look like, and also helps, you know, the providers of care understand a little bit more what is their target. It made me wonder, in thinking about the language shift, you know, is there a way to also maybe establish some positive, may not be the right term, but, you know, outcomes or metrics that reflect this idea of flourishing that was kind of resonated with Dr. Bostic's initial comment. So for, you know, perhaps in addition to preventing inpatient admission, maybe also promoting timely brief observation to improve triage accuracy, you know, some kind of metric that really has more of that positive frame on it. So in addition to preventing ER visits, also like providing immediate attuned mental health support for mild to moderate mental health difficulties. And then I guess the last one was preventing readmissions, right? Which we need as a metric. And also as the metric, you know, customizing short-term community coordinated health supports, right? To facilitate that positive engagement and functioning at home and school and the community. So just thinking about how we describe our services and our metrics, both in kind of a positive frame. Those are some of the thoughts I had when listening to your excellent presentation. So thank you.
So Jeff, this is rich, and there may be a follow-up presentation on a couple of those items. Let's go to Greg DeSherry. Greg, you've worked with a lot of folks who've gone through these types of services, and you've gone through these types of services. We'll get to that a little bit more in the Live Lynn section later, but right now, what are your reflections on Jeff's program?
Yeah, I mean, it seems fantastic. It's such a huge barrier. It was just reminding me of a young woman who I'm close with her family who died by suicide at the age of 15, and her mother continues, and this was 3 years ago now, but just beats herself up and says one of the biggest mistakes she made was having her taken to a psychiatric hospital, and that's, you know, obviously very tragic. And I think the reason why is our current places we put adolescents and to adults to a degree seems very punitive. And so therefore, you know, young people, and Karen had said this, was that she went to the hospital and she learned that, you know, I'll lie to the doctor to get out of here because it's such a, you know, horrible place. And so when that happens and the young person gets out and they get this mentality, which they've already had to begin with, which is, you know, a very much of a reluctance to say what they're going through. And they say, well, I'm not going to say what I'm going through because they're going to send me back to that place. So, I mean, I think obviously having a place that is much more youth friendly and youth focused, could be a tremendous benefit to saving lives, not only, saving lives for young people coming to those facilities, but really in reducing some of that stigma so that, young people aren't so afraid to go into some type of, temporary crisis or residential setting. But equally as important that the parents aren't so scared to send their young person to a place. And so, because I hear that often a lot, a young person will go into place, they'll have a horrible experience, the parents have a horrible experience, and so they are very even more reluctant to to get that kind of care for their young person who could really benefit from it, if it was done in a more therapeutic, a more kind of supportive and loving, sounds like cool environment that y'all have going on over there. So I would just commend you in your work. You didn't touch on it much. You did a little bit, which I'm sure you do more of, but I think just really the importance of engaging the families early on and really, recognizing that the families, need that treatment too. They need that kind of support too. And I think you touched on it from the, families are lost when their kids have mental health issues of what to do. And so as much as we can do to support them and educate them is hugely important as well.
Thanks, Greg. Yeah, no, I think there's a few myths. People say that kids are harder. They're different. I don't think they're harder. You do have to deal with the parents, the guardians, others that are in charge of that child. But they're more rewarding in many ways because you're changing the trajectory of their life, right? And I think our team feels really rewarded by that. I do think you have to focus not just on the kids, but you have to focus on the parents. We even actually focus on the schools, the teachers, the other environments that have to, kind of be aligned to make sure the kid's okay. I will tell you that part of the challenges we've seen is the commercial kids have worse access than the Medicaid kids in many ways. Yeah. And so it's how do we support that? It looks a little bit different. So the more our buildings look kind of more retail oriented, more, on the busy corner with big signs and not hiding from anything. Let's not duck this. Let's just say that this is a thing that's got to be done. And you should not feel ashamed at all about, going to get this kind of help. Is a huge deal. Thanks about the architecture and the design. We purposely designed it that way. We wanted a place where everybody was comfortable bringing themselves, their kids, whoever. I'll tell you the last thing for me is what we've realized too is there's just very different gaps in the system compared to adults. There is certainly a challenge for, let's call it aggressive, violent teens who, after they hit us in crisis, really need somewhere to be 60, 90 days that we can help manage them. It's, we just don't have a lot of those options around in the communities. I think we could do a better job. On the peer side, it's been really interesting on the peers, and we do have them, but there are different requirements, and we have to pass fingerprint testing on all of our peers. And, regardless of where they're at in the building, it's changed some of the dynamics there. It's made us think a little bit about too, how do we think of the notion of a peer sport or a family sport in a little bit different way, given that we've got a lot of challenges we're trying to face, right? And you can go down a lot of rabbit holes, right? We've seen that too. And we've had to think about how do we handle kids with, that are on the spectrum, and how can we manage them in these situations and in these settings? How are we going to handle sex trafficking victims? These are a lot of things that go with it, but we're excited about being a part of it.
So Jeff, this is really rich, and I'm hearing at least 2 or 3 different things that we may want you to come back and speak more on. But I want to just touch for a second. In my mind, the difference between crisis now and more traditional approaches is the scale. A typical crisis residential program might admit 1 or 2 people a day. If you've got 16 beds and people are staying a week or 10 days, you're seeing how many people a day?
We're seeing 100 in the clinics each day, across our 3 service lines. Our crisis beds are, except for in the summer where there's a little bit of a seasonality with the kids, they're largely full at capacity. I think you need that scale, to be honest, to have all of the people that are in the building. I mean, we have psychiatrists and and therapists and social workers and psych nurses and peers and technicians. And you need all of that team in a scale that makes it work so you can keep a safe environment for all and handle whatever will come through the door.
And I think having you come back and talk a little bit about more about rates and contracting, this is a key sort of area. People are still asking questions like, well, what's your medical clearance protocol? Nobody's being medically cleared to come to you. They're coming directly in your door. You have medical clearance, sort of what you're doing internally, but more on that. Jeff, thanks for being here.
No problem.
Rich conversation. And we haven't seen a featured speaker yet integrate the text chat. It's a lot to follow, and Jeff was just responding in real time. So let's go to, thank you, Jeff. Thank you, Sharon and Greg. I'd hope to get to Denise Zolbach and Michelle Zabel if they were available. Well, look, we're going to get more of on this children and adolescent focus as we go along. Hannah, are you wearing a 988 shirt today?
I don't have it yet. It's on its way. So I'm
all right.
not.
Well, you already have one coming. So normally a crisis trivia hot seat person would be telling us the logo and the quote. And Amy, there's only one quote to pick. Amy Brinkley, right? I mean, that's simple. But today's, and Jeff leaned into today's question, again, focused on children and adolescents. La Frontera Impact, one of the two major mobile crisis providers. These are a team of two individuals, a professional like a clinician or social worker, and someone like a peer going out as a team into the community to the person's kitchen table, the apartment, the street, etc. They deliver about 750 to 800 mobile crisis contacts per month just at La Frontera on average. But the volume does drop during the summer, largely due to the impact of kids not being in school. And that's where a lot of this gets identified. How much does overall Maricopa County mobile crisis team volume drop during the summer months, according to La Frontera Impact? So we're going to jump in here. No significant change. Well, look, Jeff just said, in his experience, it's not that. That doesn't mean La Frontera said that, though. But that doesn't seem like the right answer. B, 5 to 10. C, 15 to 20. D, 25 to 30. Hannah, you can, we're going to give you the audience feedback here. You can also phone a friend. You can phone Jeff, although Jeff's seen the answer, so he couldn't speak to that. But there are a lot of mobile teams. There's a lot of children's folks on here. Greg certainly knows Phoenix inside out. You want to, Karen, let's see the audience's view of this.
Yeah, I want to see what the audience says. Oh.
So the audience is behind C, D second, B third. Some folks still. So I'm just going to give you a hint, Hannah. Whether you're looking at call, text, or chat, mobile or crisis receiving, if you're looking at month, day of the week, hour of the day, or 15 minutes, crisis doesn't flow like water through a pipe. It comes in waves. It's against common intuition, but the strongest wave is in the spring overall. Mondays tend to be very high for crisis call centers generally. You see massive changes even throughout the day if you look at 15-minute increments of how call volume comes through. So summer is a big deal, and we see a change. What is it? Phone a friend or go with your intuition here, or choose the audience.
Well, my gut was C anyways. I feel like that would be a significant impact. I'd be shocked if it was D, but fascinating if it is. And I think that's a really important thing to look into in terms of the advocacy that we do and how we can help raise these kind of ebbs and flows and looking at the data. So I'm going to say C.
Erica Chestnut Ramirez, Erica, this is a little fluid. We've talked to Wendy, but your view of this, Erica, is the answer is
D.
It is D. So Erica, I was trying to lean into all the factors on this, and it's more than kids being identified. We have a lot of snowbirds, Hannah, in Phoenix who leave during the summer. So the overall volume of people in Phoenix goes down during summer months. But Erica, any other comments on your experience here?
Yeah, I mean, year to year, we definitely see a big drop. And obviously, we're just one provider of mobile crisis in Maricopa County. But, I always wonder, David, what goes into this? Is it that schools are so great at identifying behavioral health issues? Is that parents aren't aware of the resources. Do they identify other resources that they utilize? Do they take them more to the ED or to, you know, those kinds of
All
areas?
good questions.
What is it? And so, you know, maybe a busier mind would be, or a less busy mind than mine might be able to figure out the answer. But my guess is it's all of those things put together.
And
So,
let me pose another question. What if we had Mind 24/7 like urgent care facilities that could serve kids in urgent and crisis need more available? How would that impact this overall, Jeff? So these are the questions. But as many of you are funders or contractors, the thing to realize here is thinking about the service expectations that you're funding. These volumes, they do like this. They do it throughout the days. They do it throughout the week. And finding this balance of the staffing in order to meet the need, you know, that bubbling pot that isn't boiling over, Erica, where you just can't get to people in a need, or it's cold, that there's not enough activity going on. And Jeff Scale does get to a lot of this that you were talking about. So fascinating stuff. Stephanie, keeping with the theme and back to our flourishing versus floundering. Thank you so much, Hannah. You still get a t-shirt. It's already on the way. We're ahead of
Thank you.
Thanks for Hannah jumping in and thinking it through. And look, we split the audience good on that one. But Jeff Bostic laid some great foundation for us. And Jeff gave us a lot of the practical implementation of these concepts. But Steph, what would you point people to this week's article based upon sort of filling in the gaps here?
Yes, I think one thing that Dr. Jeff Bostic talked about was the system, the behavioral health system as it is now is really made for people who are ages 18 to 65. And he says next in line is the 65 plus crowd. Kids remain on the back burner. And I think that goes back to that initial quote that you put on the screen at the beginning of today's call, which is really, you know, the excuse for not sufficiently investing in kids is that they're more resilient. And what Dr. Bostic is saying is actually brain plasticity in those early years makes it the very ideal time to help. And again, going back to this concept of helping kids flourish instead of flounder. That said, he thinks that, you know, focusing on how teens process information, and frankly, just even as a parent to have this conversation was useful. But he's saying everybody, first responders, law enforcement, they need to be able to know how to interact with teens. And part of that is understanding how kids and teens process information, what the nuances are, especially in emotionally charged situations. They're not, you know, what he was indicating is in a heightened scenario, teens might be processing information in their amygdala instead of their prefrontal cortex. And he talks about some easy ways, like asking a cognitive question, for example, you know, is it hot in here? That can kind of derail, pull the teen out of how they're, you know, kind of shifted over to the prefrontal cortex. He does a great job of talking about why this is really important. And especially then he starts, you know, in the article, he talks about strategies for youth, which is a program that he helped to develop that was launched by attorney Lisa Thoreau, I think in 2010. And it really helps to improve police encounters with young people and reduce unnecessary arrests and use of force. And again, he goes into why that brain development is so important to talk about. And so I think, you know, going to the article, reading more about what he has to say, I think that helps to give that brain development aspect, you know, really building upon what Dr. Spight, Jeff Spight was talking about today.
You know, Stephanie, thanks so much. And Erica and Jeff both. Jeff referenced a 3-year-old earlier. So just to push this to the limit here, when I came to Phoenix in 2009, I was with the Magellan Health team. We were responsible for the crisis system. And judges in the area were pressing us. We thought we had the most innovative child crisis system as it related to mobile teams and call center. The gap that Jeff talked about with facilities was definitely there. But they pressed us because in our minds, 5 to 18, they said toddlers absolutely need this. It was the same. We had a barrier in our minds and they were talking ACEs. But Erica, your mobile teams, Jeff, you talked 3-year-old. Erica, anything you would add, and we'll have Jeff with a quick follow-up. For you're seeing toddlers, Erica, correct? And your teams are trained to support toddlers.
Yes, we are. We do a lot of training for the birth of 5 population for sure. And we're able to provide services for any population.
Jeff, any follow-up on that?
Yeah, look, I think it's when you're talking about somebody under 5, it's a tough situation, and we end up bringing in child psychiatry experts to really weigh in on this, on what needs to happen there. For us, it's been more of probably early recognition of possibly being autistic somewhere on the spectrum, and us making sure we've started to engage that side of the delivery system and those providers. But you think about I think we'll extend this to maternal mental health as well. I'm of the notion that just because you come out of the hospital in 7 days, you need to see a PCP, you come out of that birthing room, you should get a mental health assessment within a period of time after having gone through that experience, right? So I think there's a lot there that we can catch and get it earlier. But it's, again, talking about that whole family, not just the kid. We got to talk about the parents.
So Erica, when the judges were bringing this up, they were very focused on kids, toddlers, being taken from a home exposed to neglect or abuse. So they were very focused on the mental health system, the substance use, the behavioral health, mobile crisis, et cetera, being a resource in that. To what degree are you working with DES here in Arizona with those types of situations?
Sure. And actually, Impact is one of the 2 providers that does the DCS rapid response programs, which whenever a child is removed from their home by the Department of Child Safety, we are able to go out within 24 hours to do a brief mental health assessment to be able to get them enrolled in ongoing services, to be able to get them hooked up with primary care services, any type of services that they may need. And that obviously has been a program that's been around since, well, the Janet Napolitano years, actually.
Right. So Erica, Jeff referenced the autism and this being having someone who is on a spectrum disorder type of situation. This just say yes means that you have to roll up a number of these different challenges. Jeff, you referenced sex trafficking, et cetera, if we're going to do this approach. So, hey, so we've brought a new segment into the Crisis Jam over the last few weeks of a lived lens. And today we have Greg DeSherry. Greg, we didn't talk much about your background, but Greg, you've done a host of things, starting the My Life advocacy program at Magellan Health, which scaled nationally. Jeff, Greg, I think you've been a voice recipient at SAMHSA. You're a filmmaker. Jeff, Greg, the My Ascension with Emma Benoit. And what's the status of your film right now, Greg?
It's going good. We're doing screenings around the country. We had a little slowdown over the summer, but now that school's back in session, we had one 2 nights ago. Lots of people are showing around the country. Emma's traveling quite a bit, and yeah, we're definitely blessed. It's having some great impact on bringing together conversations, bringing together people around youth suicide prevention.
And Greg, are you going to hook us up with Emma for a lived lens connection with the Crisis Jam?
Oh, I'm sure she'd love to.
And also maybe Haley Winterberg as well, Greg, another peer leader that you've worked with. But Greg, tell us about your vision of the last mile. Here we are at base camp, but for us to get to the summit, Greg, what does that look like for someone who's has their own lived expertise?
Sure. So one, I just want to thank everybody on this call, some of which I recognize the names, but just for all the work that you've done as somebody who's really benefited by crisis services and mental health services for 25 years. I'm somebody who's been petitioned 12 different times into the hospital in 3 different states. Pretty much all those times I was brought by police officers. Twice I kicked windows out of police cars on my way to mental hospitals, and thankfully I did not get the shit kicked out of me in those processes. And I think that's largely due to the work that's been done over the years as far as educating police officers. For the last, I got into the field almost 20 years ago through peer support in Arizona. I went through a peer training program, then I ran a peer training program for about 2.5 years, and then for about 15 years worked for Magellan Health there, where I had the opportunity to work with David. And I had developed a youth leadership program called My Life, which was geared towards young people who experience things like mental health, substance use, foster care, and juvenile justice. And I had heard kind of relayed that people would say, well, we don't need to worry as much about kids, crisis, because kids are more resilient. Well, the fact of it is, and I'm preaching to the choir here, I know, but according to stats, on average, we lose about 7,600-ish range of young people under the age of 25 to suicide. That is 20 young people a day on average. That's, if average size of a high school, I think is around 900 to 1,000 people. That's roughly every year we're losing like 9 whole high schools of young people to suicide. That's just mind blowing. We see so much attention being drawn when people, when these mass school shootings are happening, and rightfully, so it's horrific. But when you compare the actual amount of lives lost to school shooting to the amount of lives lost to suicide, it's 10, 100 fold. But so I think a big piece of what we're needing to do is really create that public awareness so that people are really caring more and recognizing more. And I get it that the sensationalized thing of a school shooting is media latches onto, but we really need to see what we can do to have people latch on to the fact that so many of our young people are dying by suicide. I think what we can do, I think the Surgeon General has laid it out really well in a couple of forms. One, if we look to the document, which was call to action for, what was it, the Surgeon General's report. And so number 2 action is addressing the upstream factors of suicide prevention, which I don't think we talk about nearly enough. I think people are doing great work in this area, but so much work needs to be done. It gives a great analogy in that report that talks about a community where all these rescue workers are pulling people out of a river downstream, and people were dying, and rescue workers are having horrible things as a result of having to do all this. And somebody finally said, well, why don't we go upstream and see why so many young people or so many people are getting in the river in the first place. And I think that's what we really can't lose sight of. And one of the biggest things I think in that area of addressing the upstream factors is addressing the fact that so many young people are fearful and will not, don't ask for help. As we, travel around with the My Ascension movie, we've done lots of schools, and a frequent question I ask at the schools is play a little would you rather game. And I say, would you rather, if you're struggling, would you rather go to an adult or reach out to somebody for help, or would you rather just keep it to yourself? Usually about 70 to 80% of the young people say they would rather keep it to themselves. Then we ask why, and they say, well, the stigma, people are going to look at them, worse. They don't want to disappoint their parents by, worrying their parents. They're worried they're going to get thrown in the hospital. They're worried they're going to take medication. So obviously that's a huge issue, because we can have the greatest crisis services in the world, but if we're not having young people or families that are, in this case, that are willing to utilize those services or even say that they need help, then we're in serious, trouble with that. There was another, we've seen a lot of things with the things that have come out recently in terms of the need for the crisis. So American Pediatrics Foundation, the Children's Hospital, they, adolescent child psychiatrists, they came out with an emergency on mental health. The Surgeon General also put out a protecting youth mental health advisory. And I think some of this goes along with the addressing the upstream factors. And a couple of things I just pulled out of there as far as recommendations from that, a lot of which you all are doing here, but one is what we're doing right here in this segment: craft more authentic stories about mental health and consult with subject matter experts and people with personal experience with mental health challenges. Educate the public about the importance of mental health and reduce stigma. Implement an evidence-based program such as social emotional learning. I think that's a huge thing that we can really do and advocate for. Is we need to start teaching and engaging young people around mental health and mental wellness at a much earlier age. We can't wait till high school or wait till they're already drowning in the river. We need to, get them to a place where it's normalized to talk about mental health at a much younger age, so they're going to be less reluctant. And then, address the needs, which I know y'all do, as far as the of unique at-risk populations, foster youth, racial minorities, LGBTQ, other at-risk youth. So I think that is, those are things that have been outlined, by the Surgeon General that I think we can all take. And then I'll just leave you with one thing, which I think is also really crucial, and which I've done, my work with my life, and we're doing with the work with my Ascension, is if we're ever going to make any significant headway in the youth suicide problem, which then turns into the adult suicide problem, so the overarching suicide problem, we really have to engage and empower young people to be an active part of the solution. There's a lot of individuals and people that are doing great work around that now. In the film, we profile and have worked a lot with a program, Hope Squad, which is in about 1,000 schools. There's also Sources of Strength, which is doing great work in this area. There's others that are doing smaller things at individual schools. But I think that's something that we really need to focus on, because it's really that, peer-to-peer piece, and young people being, told and informed by their peers that, it's okay to not be okay. It's okay. And having those young people trained with even the basic skills of what to look out for if a young person is suffering. Because if we're not doing that, we're really just going to continue this vicious cycle. So that's my little two-minute spiel.
Greg, thanks so much. And look, this idea of care coming across as punishment underlies a lot of our current challenge, and so appreciate your focus on this being something that's okay. Jeff's getting in Walgreens right on the street corner, making it very visible. So terrific. Thank you, Greg. Let's go to Dr. Richard Mckeon with SAMHSA. Richard, your reflections, updates for today.
Thank you, David. I think that the emphasis today on youth is incredibly important for us to be focusing on. The CDC's preliminary suicide data for 2021 has shown that suicide has increased. Over 48,000 Americans died by suicide. And you can now analyze that data on CDC's Wonder site. And some of our staff at SAMHSA have taken a look at that. And, it reflects exactly what, many of the people on this call have been concerned about. It looks like those increases are particularly pronounced among youth and among people of color. So this focus today is extraordinarily important. SAMHSA is doing a lot in this space. On this past Monday and Tuesday, these past 2 days, there was an important meeting on Black youth suicide prevention at SAMHSA, a meeting of subject matter experts, which was of great value. SAMHSA has recently awarded more of our Native Connections grants, focusing on American Indian, Alaska Native youth. Shortly, we'll be making awards for our Garrett Lee Smith state and tribal youth suicide prevention grants, as well as our campus suicide prevention grants. And then later on in September, we'll be making awards for the Community Crisis Partnership grants that focus on mobile outreach and the connectivity of mobile outreach teams to other key community partners. I know we're low on time. Kate Galatis is on the call. Anything you want to share from a communications perspective?
Hi, everyone. Just wanted to let folks know that we are adding lots of material still to the partner toolkit. So I'm going to drop that link here in the chat. We should be adding some more social media shareables in time for September as Prevention Month. And then we are also really pushing on getting as many materials as we can into the SAMHSA store. So these are the wallet cards, magnets, posters, and soon to come 988 stickers. And right now, we're really moving as quickly as we can. The inventory, the demand for the inventory is breaking all ceilings we've ever seen. So we're trying to do as much as we can, as quickly as we can, and get that into the SAMHSA store. But while you are waiting on materials to be able to order from the SAMHSA store, know that everything that's available, there are the print files on our site, in the toolkit. Anything you can order from the SAMHSA store, you can also get the printer ready files and print yourselves locally at whatever way that you would do those. So those are there for that very reason, because of the challenges we're working against in terms of timing and how to get the inventory where we would like it to be.
Richard, thanks for your continued leadership, the foundation being set over a solid 20 years of work in this area. And Kate, wow, I just love everything that you guys have created. Amy, Amy has offered to skip for this week. We'll come back to Amy next week with a NASBIT update. Jack, anything in 30 seconds that you would say about next week's presentation, the other side of the coin?
Yeah, so we're going to talk just a little bit about violence and the role of crisis centers and crisis hotlines in identifying and helping prevent violent acts in our communities.
Great. Look forward to that, Jack. And I'm going to skip forward to the pipeline. Jack next week, Kate Elkins coordinating with EMS and 911 the week after. We're actually going to take October 5th off. That's the week of Yom Kippur. So we will skip that week with Crisis Jam. It'll be like Christmas and New Year's, a very few weeks a year that we do not have Crisis Jam, but that pushes our 100th episode to October 12th, and we hope you'll all join us then and hope to see you next week. Thanks for being here. Special thanks to Jeff, our featured presenter today, to Greg DeSherry, and everyone who took part. Hope to see you next time.